name is Lauren Walker. I am a reporter with Newsweek. I cover technology, international relations, national security. Here are my lovely co-panelists here. I want you each to introduce yourselves and explain your work a little bit and what you see as the new frontier of medicine. Do you want to begin, Debbie?
I'll begin. I'm Deborah Theobald. I'm the co-founder of Vecna Technologies, a healthcare information technology and robotics firm. So you just saw some of the highlights of robotics coming forward these days. We create solutions that engage patients and increase automation. And in 2009, we realized that we were creating products that service 10% of the world market and that we were leaving behind the rest of the 90%. And so in 2009, we created a nonprofit called Vecna Cares with a mission to adapt technology for use for the rest of the world. So we'll be talking a little bit about that.
And my name is Wilson Wang. I work for a medium to large size nonprofit called the International Rescue Committee. We go to about 46 countries across the world, and we that are experiencing natural man-made disasters, and we help those populations survive, recover, and thrive. The new medical frontier for me is almost like a paradox, right? On the one hand, there's the advent of new technologies, which we'll be talking about, but at least in the places that we work, it's going back to the basics, making sure that patients get the proper care for the most common diseases, which are malaria, pneumonia, diarrhea, not Ebola, and also making sure that we can use data to know how we're doing in our endeavors, and also from a public health standpoint, understand what are new emerging diseases or how we're doing in terms of controlling diseases important to the public's health.
And you?
My name is Gutman. I'm the founder and CEO of Healthtap. And Healthtap is now a network of more than 69,000 US licensed physicians in good standing that are available to you anytime, anywhere, from any mobile device or web connection, even from the watch. You can access the doctors and ask them questions. You can actually, if they deem it appropriate, they can actually prescribe medications if they feel it's right at the right moment. But they also answer questions for free. So if you have a quick question that you want to ask a doctor about things that are related to healthy living or to your health, it doesn't matter if it's losing weight or sleeping better at night or managing third trimester pregnancy or even diabetes or cancer, we have doctors in 137 specialties in all 50 states in the United States, and they're looking forward to being available to you. You can ask a question for free, get an answer in literally minutes, or use one of our premium services and then get a real consultation with a doctor on text, video, or voice, and have a conversation with a doctor. If they feel it's appropriate, they will diagnose or provide to you a medication or refer you to another doctor or to get tested. So basically, we are virtualizing healthcare using a network of more than 69,000 US licensed physicians.
Thanks. So, Ron, you explained what your product is and the problems you're trying to solve. Debbie and Wilson, can you go into the problem that you saw, the product that you created as well?
Sure. So throughout the developing countries and in underserved populations here in the United States, we see real disparity with access to care and with the real transparency into what is actually happening with healthcare delivery. And so what we decided to do was to take technologies and put them into these areas that typically have very low computer literacy, very high barriers to adoption, and to say that these are not endemic problems or things that cannot be overcome, but that we are not creating technologies that are appropriate for them. And so through Vecna Cares, we consolidated electronics into a very simple box called the CliniPack. We streamlined electronic health records, and so we made it possible for people living in these very outlying, isolated areas to be connected to a healthcare information infrastructure so that we can understand better what are their disease burdens, what are the problems that they're facing, how can we get them better resources in a more timely manner, or make better use of the resources that they have available to them. And so whether that is, resources like, doctors and pharmaceuticals and things that need to be placed properly or have access to that, or the people on the ground getting better training and better information to provide more informed care to their patients. We focus on that.
And you?
Just practically speaking, and how I know Debbie very well now is in August of last year, the IRC was asked to build a 100-bed Ebola treatment unit in Monrovia. We essentially knew how to deliver most aspects of care, especially since Ebola care is very rudimentary. It's really about stabilization and getting people through the crisis mode. But we knew that electronic medical records would be an issue. In medicine, there's a rule: if you don't write it down, you didn't do it. Even before the Ebola epidemic, people didn't write things down, and if they did write things down, it wasn't very structured, not an ability to audit well. So we thought, okay, why don't we establish an electronic medical record for Ebola care, because we knew that we couldn't have paper in our hospital. We're a pretty big organization. We thought, let's do it ourselves. And then we realized we could not do this ourselves. We don't do product development. We implement programs on the ground. And so we knew about Vecna Cares and their work, and we decided to collaborate and create the first ever electronic medical record in Monrovia, but the first ever really in the world for Ebola care. And it was a very interesting process. In the end, the epidemic thankfully nosedove, and we decided not to open up our treatment unit, and that was a hard decision for us because we sort of wanted to try out the things that we had invested in, but we instead moved our efforts to opening up the hospitals in Monrovia. People don't realize that during the Ebola epidemic, there was not one hospital and not one clinic open in that country, which meant probably 15 times the number of deaths for non-Ebola conditions.
So Debbie, when you created this product, did you see it being applied for Ebola?
No, Ebola wasn't even in the vocabulary at the time that we created it, but we did want to have a very versatile platform. We really wanted something that worked with the infrastructure, that was something you put in and that grew, that was stabilize health delivery services and augment those. So, but definitely when you see the application of, technology is all about that. You create it for one thing, but then your market drives its uses, and it could end up being used anywhere. And for someone who produces technology, that's a wonderful thing. You have one idea and you see how it can be applied over multiple ideas, then it just validates that, I solved a problem. I created something good.
So all of your products are a bit different, even though you two have worked together. I was wondering what challenges you each faced and how they were similar and how they were different. Ron, do you want to begin some of the challenges that you've run into?
Absolutely. So, bringing together a network of 69,000 physicians, U.S. licensed physicians, to engage with people and to answer your questions for free in literally seconds is a pretty big challenge, right? So, doctors are busy. They have a full life. They usually get paid pretty well. And getting them to spend time and use actually digital services or using a mobile device or a web connection to see patients for the first time. So it's not only that we bring them to actually provide a service to people, and a lot of it is actually they're doing it for free, but also we actually bring more than 69,000 doctors to meet people using digital devices, right? So mobile devices, web connections, and that's never been done before, right? So it's the first digital marketplace for accessing care. And getting the doctors to do that, getting enough people to meet these doctors, creating the processes that will enable that, building the apps that will facilitate that. First in the questions and answers that doctors are providing, then the tips that they're providing. Doctors are reviewing now news. They're actually curating these news and making them available to you. They're even rating apps and medications. You can actually see on Healthtap how a certain medication is rated for efficacy, and thousands of doctors are voting on that. So bringing them to do that, and then bringing the technology that will facilitate that and build the marketplace, and eventually create these connections that basically are as if you see a doctor right now. You push a button on your watch, you can see a doctor in seconds and have a private conversation with them, And they can prescribe a medication that waits for you 5 seconds after the consultation in a pharmacy next to where you live. It's like magic. So putting it all together is one thing from a technical perspective, and we have the best technology team in Silicon Valley in healthcare and even beyond. But beyond that, it's the engagement. The doctor engagement is the challenge that we've conquered in the past 4.5 years.
Wilson, did you have a similar problem with getting medical personnel to use technology?
Yeah, I mean, pretty much when you live at work in places like Liberia, you have all sorts of challenges, and so it's fun to categorize them in different, put them in different categories. I mean, certainly the problem of having access to a doctor is a problem. In Liberia, there's one doctor for every 20,000 people. There's 150 doctors in the whole country. Just to put that in a context, in this country, there's one doctor for every 350 citizens. So certainly that is a challenge. But when you work in places like Debbie and I work in sub-Saharan Africa, you don't rely on doctors because there's so few. You rely on other health professionals like physician assistants, nurses, and then you use technology or something, sometimes your technology is a checklist, to make sure that they have the intellectual backstop to deliver care. In terms of challenges with our product, it actually wasn't so much a challenge on the ground in terms of having users use touchpads for the first time. It was actually quite easy for them. It was very intuitive, and I think that's a good lesson in technology. If it's intuitive, it's going to be a successful product. One challenge that we would normally have, Debbie had already solved. If anyone who's lived in Monrovia will know that it rains for 4 months of the year. It's the wettest capital in the world, so you don't get an internet signal. I mean, you live there, you're just sort of kind of lonely for 4 months. And so, and then the power always goes off. Someone either steals the gas or, there is no gas. And so you can't power your technology. But Debbie had, and she can explain it on her own, had dealt with that issue, basically coming up with this great Clinipack that could be run off a car battery. And where can you not get a car battery? I think our biggest challenge was really in the development of this electronic medical record for Ebola care. I'm a doctor, so I can say the practice of medicine is quite easy, right? It's really sit down with someone, get your history, put it in the available diagnosis, and give a treatment according to the evidence. But to put that into a platform was extremely difficult because someone like me doesn't really have technical or technology and programming background will say, well, we don't want to say reason for the patient came in. We want to say chief complaint. Can you change that really quickly, Debbie? Like today? And that might take, a half a week, right? Because there's a lot of code to go through. So different expectations about language, structure, pace of change, and then the intellectual property issue is a big one. In my world, I want to create this product and give it to as many people as possible, ministries, countries throughout the world. And if we did that, I'm not sure Debbie has a great business model. So to learn this and to more importantly reconcile these challenges was very fun for us.
Did you have anything?
I definitely think there were a lot of new frontiers, and as you've heard through the panel, it's basically rejecting the traditional care models. Where we have these blinders on about how care should be given or how things should be done, and starting to think outside of the box of maybe that's not the best way. Maybe we can do more outside of the brick and mortar. Maybe we don't have to be hobbled by some of these obstacles. Maybe we can streamline things a little bit more effectively or bring in other resources. So I'm really a proponent of getting outside of the traditional ways of doing things, questioning why they're done that way. And I think some of the good things about bringing a technology partner in, cahoots with the clinical is for us to talk different languages, for us to challenge ideas, and to start to see, how can we make improvements by this interdisciplinary approach. And so I think that's been a really fun conversation with us as we've challenged, what can we actually make happen in these areas and these new emerging diseases or in strengthening health systems that have largely been forgotten over the last decades.
I know in the beginning I asked, what do you think is the new frontier of medicine? Do you think that your products are going to replace how healthcare is traditionally carried out? Or is this more of a supplement?
Yeah, I think that Healthtap has already been perceived both by doctors and by people and patient as augmenting care, right? So I think that this whole notion of virtual care, right, making doctors available to you 24/7 from any mobile device or web connection, is something that's very valuable to us. But the doctors among us will tell you that there are a bunch of things that need to happen really in the real world, need to happen in the office. Need to get a physical examination. Sometimes the doctor needs to see you. And these kind of things are, we get more and more use cases, with wearable devices, with remote monitoring, with things that you can do at home, even with the sensors on the watch. And we have an app called Doc Now on the watch that actually can take your biometrics, directly and connect it to a doctor in like several seconds. So you can do more and more things remotely. But I still think that there's a good component of medicine that still needs to happen in person, still needs to happen in the real world, whether in the kiosk that I heard that are done, or in the office, in the doctor visit. I think that the next frontier of medicine, and then if you look at some of the things that I wrote about it, is by 2020, every doctor in the world will have a virtual practice alongside the real practice, because there's so many cases that can be solved on your mobile device, through a web connection that doesn't require going to a doctor, but there are certain things that do. So what I think doctors will do and people will do will go back and forth. What really needs to happen in brick and mortar, that is expensive, that requires the high touch, will happen there. But more than 50% of healthcare can happen via virtual channels, and this is where Healthtap comes to play and provides these connections, creates this technology that is available on iPhone, Android, iPad, Android tablet, web, and now on watches to connect people with doctors anytime, anywhere.
I mean, for me, the new medical frontier is regression back to the things that we know to be true. Patients that go to see their provider, they need to get care that is supported by the evidence, not nonsensical care, extra medicines, or not enough medicines. They have to get the right care. I think the other new frontier is that the patient needs to feel empowered, and that they would have a say-so in what kind of care that they deliver. And the final one is that we can't just look at ourselves in isolation. We have to look at ourselves as part of a community. And I think the Ebola epidemic sort of made people aware that if you don't take care of people elsewhere, they're going to come into your community anyway. So a community broadly defined. And so in terms of an answer to your question, an electronic medical record here and abroad is the future. There is no going back to paper. Paper is ridiculous. I mean, to audit just the treatment of common stuff right now is next to impossible. Just to even know if someone saw a patient, you cannot know that in real time. Just to know how many people died in Monrovia yesterday, who has what, impossible to know. So all that is coming from a management of electronic health data from the facility level, but then used at all different levels to make sure that we have good care on the bottom, and on the top that we have good health policies that help sustain care for populations and not just the individual.
And we see the electronic medical record in these markets and the virtual care as just the beginning. And it's laying a foundation that allows us to bring in all of the new and emerging technologies that are coming. So we look forward to a day when our CliniPack is in all of these underserved and rural and developing countries and allows them to have access to all of these tools, such as rapid diagnostics, portable ultrasounds, and even robotic care. We did bring a robot to the Ebola treatment unit to see how it could be of help in these isolation zones. So it was a telepresence Vigo robot, and we were going to use it to support caregivers and trainers and other things as people dressed in their personal protective gear to go in and take care of people where people like myself should not be, but can be giving support to them using the electronic medical records and other tools. This was a controversial step. It was pushing the limits of people's tolerance for technology. But that's something I think that should happen. There's nothing that we should hold back and say, this technology is not for you. This technology is inappropriate. If it meets a need and it's meeting a demand, people will adopt it. They will understand it. Just as the virtual care and some of the other things that are going on in healthcare, people may say, that's too far. I think that's for the market to decide. I think that's for the patients and for the people generating demand to decide if this is going to be something that really changes medicine.
I think that was a wonderful note to end on. Thank you so much. This was a fascinating conversation.
Thank you.